Angle Healthcare is my company, and what we provide is a management service organization. And once again, the goal is to build independent physician practices that survive and thrive in the current environment. Today, the MSO is not a luxury for practices. It's kind of the difference between staying independent with your control or slowly losing margin, time, negotiating power. So once again, my name is Michael Ricchiuto, and I advise the independent healthcare practices, keeping them independent and moving forward. Now, my angle at this is, let's talk about supporting business benchmarking, reimbursements, improving revenue cycle, tightening scheduling and staffing. This is really difficult to do, especially if you're a solo practitioner. You have a lot of forces that are coming at you from this side. And really, the bigger organizations, how they do it is they have individual professionals who are the CEO, the CFO, the COO, hiring managers. That's not what the independent practitioner is facing. They actually have to face all of this at one time, and that's overwhelming. So if we take a look at some of the biggest pieces of difficulty on the business side for practices, you'll see it kind of streamlined into administrative and operational pressures, financial and insurance complexities, staffing shortages and burnout, and then the need for operational support. Overhead, reimbursements, and delayed payments are some of the biggest reasons for an independent practice. I don't want to say crashing, but losing margin, and certainly not becoming independent in the future. So this is kind of what we're looking at. We're looking at frustration sometimes. You have only so much time in the day, and you have all of these, I call them subtle pressures that are around you every day. So first of all, you're seeing patients, and not just you, but your team is seeing patients, providing the best care that you can, which is always excellent care. But on the back burner, in the background, you have things that need to happen so that your practice runs smoothly. Technology, you need to have the finance in place, meaning, what are the numbers looking like from weekly, monthly, quarterly, and yearly projections. You need that. You need a good tax strategy, a revenue cycle. How is your labor and your HR systems? Are they efficient? Your suppliers of all of your goods, what is happening there? That's a pressure as well. Are these prices too high? Are they not being utilized the correct way? Is there waste? And then marketing and sales, something that kind of goes in the back burner for practices. And marketing has to be occurring at all times. It doesn't have to be paid. It doesn't have to be in a fashion where a lot of money has to be spent. If for independent practice, it just has to happen, okay? And then it snowballs. So these are the things that are on the physician's mind in the back burner after you've spent 3 hours charting because you had 20, 25 patients a day, and it really leads to the burnout that a lot of practitioners face. Great. So from all sides, we're seeing, from a bigger picture, we see things that are happening behind the scenes. This is stuff that we don't have control over, okay? Inflation, rising costs, hospital buyouts, technological costs, and reimbursement cuts are some of the big ones. So literally, this is the shrinking reimbursement that we see from a global view, from a macroeconomic view. We can't control these things. These are these are going to happen no matter what. But how we react to them and how we pivot with these things happening means all the difference in either growth or having a stagnant practice with no cash flow, or not being able to survive. Okay, so let's take a look quickly at inflation. All right, so this is the last 10 years of inflation. 2016 to 26. And we all know there's a lot more pressure than there used to be. So the average inflation rate was in the 10 years is 3.1%. Over the entire 10 years, the cumulative inflation is 35.7%. And then the price of rise in prices is the same, which is kind of high when you take a look at what happened the 10 years prior to that. So here we go from 2006 to 16, we have really kind of low inflation, 1.9%. The accumulation of inflation is 20.7%. So, we were working in times that were conducive to business growth, and we all know that the reimbursements were higher because of a 33% cut in physician payments since 2001. So in this environment, some of the companies that were formed are not able to survive what's going on in the current environment, which is kind of turbulent, right? So this shows up as lack of cash flow and being buried in overhead. And that's the kind of thing that you have more leverage than that. There's definitely more leverage, and that's kind of what we're going to be talking about a little bit as well. If we take a look a little bit more, 2012, we saw more physician practice consolidation, right? We're just going to take a look at 2012. We had 60% in America of private practice owned by physicians, and then 40% was owned by other entities, like private equity and hospital affiliations. And then here we are, this was 2024 was this study from the AMA. We're now at 42% that are owned by physicians, and then 58%, there's been a lot of consolidation, right? A lot of other entities that have taken ownership of physician practices, which we can't let that happen. That's ridiculous. So the leverage that the independent practices have is less than it used to be. Having an MSO model is a counter strategy to that because it allows you to pivot the infrastructure, the analytics, and the operational standards and contracting support that otherwise would be lost. It's kind of like having I always say it's like flying a plane without the altimeter. You don't know what's wrong, so you don't know how to fix it. I guess it would be apply the same thing with medicine. You have to have that diagnosis before you know how to treat something. And it's the same way on the business side. You need benchmarks, KPIs, operating standards, and you need to know when something's out of place or not financially stable. You need to have that altimeter. You need to say, hey, wait, why is this not congruent with what's been going on before? And why is it dropping? And what do we need to do to change it? And that's where the MSO comes in. Those altimeters are set for practice growth. All right, so let's keep going. This is one of the biggest problems. I assume that many physicians know what's been going on with obviously the Medicare rate cuts, and I always talk about the Medicare Economic Index, which was put in place early in 1992. What it's really supposed to do is it's supposed to leverage the inflation that's happening in practice and physicians' practices. It's supposed to meet that with the government being able to basically match inflation so that physicians can keep pace with inflation. Well, unfortunately, the government, they stopped doing that. They actually around 2020 to 26 here, they just implemented almost depending on the year, a 0.5% increase. One year was 0.75% increase. Meanwhile, you just saw in the last slide that we're increasing by 3.1% year over year. So literally, they're not keeping up with their bargain and keeping the inflationary rate for physician reimbursement going forward. And they're not connected. So CMS is able to say whatever they want to say. And then, the policy here is kind of getting shoved under the rug a little bit, which is just, and it's related to politics. Who's in office, who's not in office. Thank goodness we don't get into that here. But that's where we see the decline. And when you take this into account, here is the chart from 2001 to 2025. And literally, here's the inflation index right here. And you can see right around 2020, it just takes it skyrockets because they basically, decided, okay, we're just going to be at 0.5% or 0.75%. Well, here's inflation, and then they're not meeting up with that. So this margin here is lost. And there's your 33% decline since 2001. And this applies to all, anything that is covered by Center for Medicare and Medicaid Services, right? So that's all healthcare. And if you're you're under the physician fee schedule, then, and I think almost everything in medicine is, right? We're all kind of seeing the same thing. Okay, I swear I'm not all doom and gloom. I promise you. Okay, but let's take a look at this. So let's talk about a little bit about my history. I own 2 physical therapy practices, and it's similar rules. We are also, CMS, CPT codes, ICD-9 codes. And this was, so I've had the practices for 20 years, and the best way to describe the levers that anybody has in their practice is to describe what happened during the COVID year. Okay. And so there were some things that were done were blind. I did some things that were blind. In 2019, we had this profit margin of the company, 6%, which 6 to 10% is, it's actually subpar, but it's manageable. In March of 2020, we had a 74% drop in revenue, okay? Because that's how many patients did not come into the clinic. I'm sure some of the practice owners on the call actually have seen the same thing or even worse. A lot of places closed up. And here's the interesting thing. By pulling certain levers, we were able to profit 21%, which some of them were blind because they didn't know what I knew now. And I actually went back to school to learn what I need to do, to achieve these things that happen very quickly when there's a pandemic, right? So we'll get into those levers. And I think that's what most people want to know is what are the levers there? So, but once again, the things that we cut back on or changed, okay, the patient volume went down 74%. We had PPP funding, but it was too late. Okay, the drastic, the rent, the payroll, the suppliers, the advertising cost, on and on and on, was way too much the overhead for anything that we would support. We were basically on a downhill, like free fall, right? So here's what happened. And it gave me the surprise during a really critical time as to what I could do without just saying, bring in more patients, right? That's what we assume. We assume my cash flow is going to improve if I have more patients. Well, it does. It can, not always. There's practices that I've worked with where they have a great stream of revenue that's coming in. They have plenty of patients coming in, but equally, the value and the revenue is going out the door from systems that aren't in place to capture actual monetary change. Okay, so things that they don't know that are just bleeding them of any type of cash flow they may have. So overhead. So the cost went up, the profit margin went up because of, and I think I have it in my next slide. This is what we did. Okay, so it was March of 2020, and no one was coming in the door. And we offered the staff, we had 11 on staff, and we offered them to either stay on and, an unpredictable, health and financial madness. But we offered to have them stay on. We were fully open, of course. Or we said to them, you can stay on and we'll figure it out, which isn't a good strategy. Or you can be laid off and we'll hire you in 2022 or 2023, whatever happens to get you guys back on. We had 9 people say that they wanted to just be furloughed, and they were. And the good news is, at the time, I wasn't sure how that was going to play out, but the good news is that they were paid better because of the grants that happened to the state, to what the government was trying to do to keep businesses afloat. They actually, had their pay. They got paid better as employees than I would have paid them, and the taxes weren't on them. So like they were happy, but that wasn't enough. So labor should be approximately 40% of your total spend. It's a big part of what can be changed, but that wasn't enough. So we actually at the time had 4 clinics. We closed 2 of them. We ran 2 of them, and we ran them for 7 days straight. So, and we went between two of them. It was really a crazy time, but we did that. We halted all the marketing that we were spending on. We renegotiated with our landlord on the rent. We closed down our supply chain, because guess what was happening to supply chain? It was frozen. We weren't even getting the supplies that we needed. And thank goodness, we're a physical therapy company, because if we were a medical company, when we needed IVs, that we needed syringes, we needed 4x4s, if anything, like the medical practices will go through more supply, we really wouldn't have been able to do it. So we were able to do this and make it so that we were profiting, even in a time where everyone was falling out, right? And some practices never came back. I realized after that I needed more help in my education to make sure that this would never happen. And if I survived this, I was going to make sure that I could provide this for other clinicians, no matter where they were, who they were. I don't want anybody to go through this tragic time. In this time, this is a profit and loss statement, and one of the biggest levers of this is kind of interesting. A little bit of it is as an example. It's just a small chunk of some of the expenses for payroll. I made this example for just payroll in that time. So if we have, January 1 through December 31 in 2020, I just took 2020 because it was a real critical year where we learned a lot. If we would have, and everything's the same for just moving the payroll. So if we would have kept the payroll how it was in 2021, it was also the same in 2019 at 450,000. Okay. If we would have kept it the way it was, where we had clinicians on, literally, we talked about the 40%. What we have here is literally a deep dive just from labor to 35,000. And now there's income, so that's great. But look at the dive. If we wouldn't have changed labor, we would have, the difference is 153,000 to 35,000. So just changing that labor component alone can cause drastic swings in what happens to your practice. Now that's just one lever. That's just labor. You add supplies, you add admin, you bank charges, EMR. If you have all of these things running at the same time and you don't catch them, what ends up happening is you can be in the red very easily. And I think a lot of folks probably on the call can they can relate. They can relate to just one of the levers causing such a problem, but then all of the levers can bury you. So that was kind of my goal, or just take a look at this and see just one factor, which is a big one. Don't get me wrong, payroll. So COVID happened. And I was like, okay, I need to learn business, right? What I want to do is I want to specialize in saving practices, because once again, the sanctity of medicine is in the autonomy of medicine is in private practices, not corporate takeovers, not hospital systems, not the reimbursement. That can all happen, but we need private practice to stay. I basically, right here where I said that COVID just taught me what I was missing. So then I went back to school. I went back to school, and I went back to school and I received my MBA at University of Pittsburgh, and in healthcare, specifically specializing in startup practices and private medical practices and hospital practices. But mainly, my love or my true passion is to make sure that the independent private practice stays independent and autonomous, so that they're not bought out by corporations, private equity, hospital systems, or we all lose. We really do. Patients lose when the structure is taken over by these entities with high administration and they have other things on their mind. They're looking at monopoly. They're looking at financial structures that don't involve patients. The bigger is never better. I always say it just isn't. So that's what we do. So once again, I kind of tapped on this. Personalized patient care is in the independent practice. Autonomy and innovation, the things that are created in private practice through innovation trumps anything that you would see in the corporate atmosphere. The private practice is kind of like a speedboat on the water. You can make changes quickly. You can educate quickly. You can pivot fast. You can streamline the future of practice by creating what you believe is patient care faster without the administrative hurdles and operational hurdles that you have to go through in a hospital entity. And then this physician-patient relationship is held accountable and is the primary focus when you have the relationship. There's nothing else like this, like in America. So we need to preserve this. The decisions on clinical judgment and clinical decisions are primary to the physician relationship when there's no barrier in the way. And this is why this is so important. Let's take a look at some upside, because I just presented a whole slew of downside. I want to give people some upside. We're needed more than ever. Okay, literally, musculoskeletal rises in musculoskeletal disorders is, once again, here's a nice little stat: 95% increase since 1990. Here are our key drivers. We have high prevalence in aging populations, economic impact, shift to non-surgical care, technological integration, education and specialization. Okay, training toward ultrasound and joint injections, ERP, some of the conservative injections. And we have not only a United States growth in this whole equation, we have a world, we actually have here it is, 1.7 billion people affected worldwide. So it's a global concern, because we have to meet this demand. And private practice can do this. Here's a interesting fact, a continuous annual growth rate. So that's the growth rate of demand, is 4.5% from 2026 and growing. So 4.5% each year. That's huge. And it's growing. It's just, we really have a lot of demand. So we need autonomous practice to meet that demand. And what I think of I think of our small communities. I think of our communities across the nation that rely on those independent physicians to get care, and not in the bureaucracy of a possible hospital system, or access to care. The access to care in a private environment can take so many forms where they can get care. And we're really looking but the financial side has to be on target with it. Accepting some of the low payers can work in volume, can work in payer relationships. It can work. It just needs to be formulated the correct way. And access to care, we know, is less. So that's why private practice is a savior in this aspect. All right, so let's keep going. MSO. Okay, so what is MSO? We'll talk a little bit about this. Practice infrastructure is basically everything but the clinical end of things. Usually, there's a financial dashboard that will have all of your altimeters, all of your levers. It also goes through every thing that you would need in your practice to succeed. Care strategy, marketing systems, financial reporting, technology workflows, marketing systems. Everything has to, unfortunately, be a system. And that's because it can be predictable and reliable, right? There's compliance processes as well that go through an MSO. The good news is that when you have the business structure that's working on the business structure, and you have the strong clinical support of the physician and their team working very hard on the clinical end, if those two are connecting with proper workflows, that's what will build a practice, because you're not leaking money through systems that are inefficient. Okay, and we'll go through those as well. And when they're inefficient, then you see things like, oh my God, we can't make payroll this month. Or yes, how did we come in this year? We know that there was cash flow, and here's our bank account, but did we, should we have received more than that? Did we lose money on things? That's not a good way to practice. And I see a lot of practices doing that, where they're shooting from the hip, right? Shooting from the hip financially. But remember, there's all these pressures on the physician or the owners that make it very difficult for them to dive into this kind of structure. And that's why an MSO partnership is really important. Okay, so Angle MSO, these are the kind of things that should be looked at really with any MSO, and not just ours specifically. Marketing, okay, it's very important when you mention that. Sales, how your supply chain is working, your human resources. There's two things that you can do to survive and thrive, and one is your systems, okay, are solid, and then your people are solid. Okay, so you need systems. If you would break it down if you would say, hey, Mike, listen, what are the two things that are important for a private practice? Systems and people. It's just clear cut like that. And once you have that, you can then filter into the things that either go to systems or people. Okay, but all of these things have to be in place. It's very important. In our MSO, there's 7 pillars of practice growth, not survivability, but growth. Once again, marketing, sales, supply, we mentioned those. Human resources is big. You have to have systems in each of these, and we'll talk a little bit more specifically about what all this means. Financial planning and analysis is critical. That's kind of like, do I have gas in the car? I don't know. Well, you should know. And if there's less gas, you'll go to the gas station. But if you didn't know, you'd run out of gas on the road. You wouldn't know, and it would be too late. If there's a change in one measure, one KPI, you need to address it. And is it something that is a one-off? We call it a one-off, or is it something that is continuing to be the same or declining? And if that happens, let's now look into the operations to see where, and let's correct it. So from an operating side, I have the good, advantage, and it's really, I'm blessed to be able to go into the operations of the healthcare operations, be very familiar with this, and then find out where the bottleneck is in the whole chain of command, the operations and that kind of stuff. So it starts out with the dashboard. Where are your KPIs? Are you on track? Are you on target for your financial measures for the year? And if not, why? And then if not, let's look into that deeper. And if not, from there, let's look into these systems. Where is it in the system where we're not pulling our weight? And then from that point, you can correct and move forward. So that's kind of how MSO works to grow a practice. Speaking specifically for marketing, we're going to just kind of tear that apart a little bit. What does that mean? It's pillar one. Marketing is a couple things. It's brand and positioning first. Your brand has to be on target. You have to not change you have solid colors, you have an emblem, it's trademarked, and then you can present your brand wherever you go or whatever you do as a unified brand. It shouldn't take on different colors. It shouldn't take on, there's certain non-negotiables when it comes to a brand and where you're positioned. You should be able to use this brand of yourself, of your specialty. You should be able to use this in the community personally, personal networking, talks. You should be able to have open houses. You should be able to have networking events, stuff like what I'm doing today. You should be educating the community. You will develop a spin in the local community. You also have to have a digital presence. Okay. And what that means is, what does your website look like? It doesn't have to be fancy. It really doesn't. It just has to do the things that a website are meant to do, which is attract patients, qualify your brand, and then be able to schedule. Okay, really, every website is only a few things. It's meant to be a funnel to be able to schedule. And then when someone schedules, they need to be able to do it quickly, efficiently, and someone from the staff needs to really specifically be able to respond fast. Okay, we're in a quick digital age where someone can either call your clinic or they can go on another site that's on the web. Maybe there's no location. And remember, that's another pressure. So they can just call that, or just, sign up for an online examination. I'm going to be honest with you, there's a place for that. Okay, there's a place for telehealth. There's a place for online scheduling and having care online. There really is. But the majority of people want to see their physician. They want to have a relationship with their physician. There's a strong advantage with the physical presence physician who is in their community, serving the community. It's not going away. It's only growing. So there are two types of people, maybe three or four, and some of them will be drawn straight toward that digital. I just want to, doc in the box, they call it. But the majority of folks are not that way. Okay, humans like interaction. They like to be looked at physically. There's plenty of room here for both, types of stratified patients. And lead tracking. Okay, so it's not good enough just to have your marketing to be able to, be out there. Hey, so-and-so clinic is having this. No, we need to know, if you are spending money on your marketing, how much money, where is it going, what is the cost of the ad spend that you're spending to acquire and achieve a patient? Okay, there's numbers there. This is very specific and objective. How much are you spending? What is returning as evaluations or examinations? That has a value to it. Your cost per ad spend, your revenue that you're receiving per qualified lead. Are your leads converting? All of this stuff is tracked. Okay, it should be tracked. Why? Not because you're trying to just be this person, this clinic that's trying to just, be the monopoly of no, you have to have predictability, right? You have to have predictability. And then you have to know if you're spending too much on something, right? Or you're just throwing money out the, out the way. It really has to be qualified. We need to know. And so here's another thing. If you are spending this money, and you're converting, well, that's great. Well, is there a better place to be spending your money? Okay, if I get one lead from one source that I'm spending a certain amount of money from, is this worth my effort? Or is I'll spend no money and I'll have a talk or something and I'm converting leads there. So it's not only, it's benchmarking yourself of the marketing for what is the best use of my marketing dollar. Okay, and that's where marketing really is more objective than just throwing, ads on Facebook or Instagram or blindly doing things. It has to be qualified. You don't want to, you have limited time. So you want to be spending your time literally in the best areas. And this is how to kind of make that happen. 3 ways, and I won't spend too much more time on this. Sorry, this could be its own lesson, but 3 really good ways of looking at marketing: physician referrals, referrals from other physicians. Great, the network is fantastic. In person, also, just being able to refer back and forth with physicians is really great. Or other clinicians, nurse practitioners, other clinicians. As a physical therapist, I refer to my primary care all the time. So there's other avenues that people don't think about. Web and social media, we talked a little bit more about, and then community awareness. Okay, they know you're in the town. You are sponsoring events. You can be the trusted physician in your community. That's powerful, especially if you're from an area where you might be the only physician in the area. Maybe no one knows you're there, right? Even if you're the only one, maybe no one knows you're there. So there's real things, and then there's places like New York City where everyone is there, but it's not the physician that is the best physician that ends up getting the patients. I'm going to say that again. It's not the best physician clinically that gets the best patients. It's the physician who presents themselves as the best physician. All right. So there are things that turn the consumer into saying, I need an appointment. Unfortunately, it's, you have to have good care. That's it, period. But there are not good providers having a great marketing social media platform that bring in patients. And maybe they're not the best clinicians. That's for the patient to figure out. But it's presence, and the presence is very important. Let's talk quickly about sales. Sales is not an evil word. It's not. It's actually being able to provide your services that you deliver. And this has to happen within the team. Right here, everybody's rowing in the same direction. Front desk, clinical team, physicians, back office. Everyone has to know what the physician is expecting from the patient visit. So does the patient, but it has to be buttressed by each level of contact that the patient encounters. The front desk has to be in sync with the physician, nurse practitioners, RNs, back office. They all have to have the same agenda. They all have to have the same ability to convey the message and what the physician wants. Okay, if the physician's ordering these certain tests, they have to be backed up by the support staff, and the patient has to be obviously informed. They have to feel like they are part of the process. The physician's just not barking orders, and then all of a sudden the patient's like, well, I don't know if I need that. Okay, there has to be communication throughout the entire process to actually work. And that's really what medical sales is. It's communicating throughout the entire visit that gives people trust. And that doesn't sound like sales. It sounds like good communication. Well, you'd be surprised at how many broken processes are there when we have a sales strategy that doesn't work because of this, the lack of communication. And that's really what we're talking about, sales. So that has to be in line. And how does that become in line? Your team has to be, you have to have team meetings. You have to have, I usually break them into a daily huddle, which is a quick 5-minute, 10-minute at the beginning of a shift. There's longer meetings that might be weekly. There's monthly, quarterly, and then in the back end, there's a yearly meeting. So it doesn't have to be long. It just has to go over the key components of not only the business structure. It's separate than the clinical. Okay, so you can nail this out. You can nail a huddle in about 5-10 minutes, hitting all the business structures, everything that you need to do infrastructure wise, and then you can also nail all of the clinical side stuff at the same time. And that's kind of things that I've implemented, which works very well. You have to hit a rhythm. The rhythm has to happen weekly, to go to monthly, to go to quarterly, to go to yearly. That's the best way to start growing a practice. This is pillar 3. It's supply chain. And what is that, right? It's kind of like, I don't know what supply chain is. Supply chain is just the patient flow. So first of all, what has to be, before any of this is even looked at, what does your space look like? What is your actual space? How is it set up? Is it set up for flow of the patient that is, the stream of patients is in a good flow where it's productive? For instance, I have in the next slide, I think I have a time. We'll just look at this first, then I'll get into that. Patient arrives, they have the evaluation, the treatment, the checkout. So that process is called throughput. The time that they come in and the arrival, and actually before that, the scheduling is a part of that. The time they come in for the arrival, start the clock, and then all the way through the checkout and until they're done, then hit a clock. That time is your throughput time. So you're looking at that, and that's going to determine, believe it or not, your cost per visit, your revenue per visit, space and capacity demands, and your revenue opportunity. Okay, just from having the space laid out and having the flow of the patients happening. This is one of our dashboard that we put together, and you can take how many actual patients are being seen. Here's Dr. Adams, Dr. Bennett, the nurse practitioner, and the benchmarks for what you're trying to achieve. Why are you trying to achieve a certain amount of patients? Because it means a certain revenue will most likely be achieved. If your financial side has said, okay, this is what we're going for a year, this is what we want to make profitability wise, then it has to be substantiated by a couple things. One of them is this: it's the supply chain and how many patients can be seen throughout here in an hour's time or whatever time you have set. But you have to have these things measured: waiting room time, intake time, and you set your goal, and then here's the variances of those. Is it happening? And then under which physician is it happening? Under which provider is it happening? All of this makes a difference because the utilization of the room, same day discharges, all of this stuff is really bottom line profitability. Okay, you're losing revenue when this is not streamlined. Okay, and there's through some calculations, there's ways to improve this process dramatically. Human resources, another source of leakage. Okay, attracting talent, there has to be a process for that. The right talent. Everyone has had everyone. There's just like everyone has, employees that haven't worked out, employees that you hired and it just didn't work out. Maybe they ghosted you, or maybe they came in for a month, or maybe they just didn't work out. Maybe they were toxic in the culture. These types of things so the hiring is the most important. Okay. They always say hire slow, fire fast. That's true. You always want to have that clinician vetted before they start, and they have to fit your culture. And they have to be obviously competent, and they have to know what they're getting into as well as what you're getting into. So there are systems provided in an MSO that will allow you to get those. And what's the attraction process, right? How do you get those great clinicians? And is it always about money? It's not. It's really not. It's crazy, but it's not. So getting the right talent, onboarding them, not just setting them loose on day one. They have to fit your culture and your systems, right? Training and development has to continue. They have to continue to be competent, and they actually have drivers, internal drivers themselves, like we all do as humans. We all have internal drivers as to what their career is going to look like. And you can expose what they really want up front before they're hired to make a good fit there. The retention process, the process of what it looks like year 1 through year 5 has to be set out, because as human beings, we don't like change, but we need to know what is expected. Everybody knows they want to know what's expected. And then you have to keep them on guard with the business side of things and how things are happening, because they're part of your team. You're a team, and then the compliance, there has to be policies in place, things you can't do, things you can do, and it has to be enforced. So there's a lot of that. And for some solo practices, that's not happening. It's just put your ad out on Indeed, hire the first, medical assistant or something else, get them in the door because we're losing patients, or we can't see enough. That's not a good strategy. It's just not. You have to hire the right person, and it will pay dividends. If we look at this labor and revenue capacity analysis, here we have, a couple physicians, these are all kind of made up. And then we have other practitioners. The revenue targets for the year, that is set out with their involvement. You're setting these things out. You're giving them what you're expecting, and then you're kind of compiling in a review, and the reviews are another thing. You're setting out what's expected, what you're looking to do, and you're combining each other with each other. You're combining your involvement to say, yes, I agree, I can do this. This is something that I think we're going to be able to tackle. So all of your goals are shared goals, and they have to be revisited. Okay. And here's kind of some revenue gap that we found, and maybe here's the target, and then here's our goal was 80%. Some of these aren't making it, some of them are. And if this happens, you're never firing. Here's the key to longevity. You're never firing someone unless they're just blatantly not working out on the team that you would do. But you're finding this gap. You've just found some, a KPI that's off. How can we get them to here, to this goal? That's the missing connection between management and, employees is this achievable? Is this something that is, can be achieved? And if it is, then how do we get that employee there to meet that? But if it's something on the operations side, for instance, I'm a med tech and I need to do, 15 MRIs, right? That's my metric. I can do 15 MRIs a day. And then there's no marketing or sales side getting those patients to the technician. They can't meet those goals. So that has to be part of this thing. Maybe the goals need to be reset, and that's kind of the longevity component to hiring the right person, having the right person on, and then actually being logical about what can be achieved. And like I said, it's a little bit of a give and take with sometimes, but that's how you keep people. We've had the same people. All of our people, we got them through COVID. They're still working for us. So you can, and it's not all about money. All right. So there's a lot of satisfaction when you're a employee with stability and being in a great environment and having culture. Fifth pillar, I know this is going on, but I won't keep it too much longer. Fifth pillar is financial planning analysis. Number one, you have to have cash flow. That's king. Cash flow is king. It has to be present each month. You're not going to have a month where cash flow is going to be positive. But comprehensively over the year, you need to be positive. This is the lifeblood of a practice. Yes, you need to know what's happening monthly, or weekly, monthly, quarterly. I usually set my targets for quarters. Okay, here's the year, but then quarter one, this is what we're going to achieve. At quarter two, we're achieving this 30 or 4. But month one of quarter one, how are we doing? Are we in line to maybe meet our quarterly goals? If not, well, it's the beginning of the year. What are the nuances? Are there pairs, maybe there's deductibles, this is assuming that you are taking insurance. This is a little different when you're not taking insurance. But it's just little nuances, but it's kind of business is business, right? So we'll stick with like just the insurance model because it's so prevalent. So in the insurance environment, you're like, okay, well, there's deductibles, there's co-pays. It's the beginning of the year. There are people coming off of holiday. So there's all these little kind of things that, depending upon what type of practice you are, might be a reason why you're more of a cyclical cash flow instead of a consistent cash flow. It happens a lot in our practice, the time of the year and when people have, their co-pays, deductibles paid, all that stuff. Anyway, long story short, you need to have these targets set up. If you're not achieving them, why? And you can deep dive into these. Okay, you can find out what the bottleneck or the driving agent is with this. But it does involve sometimes accounting. Your accountant usually doesn't do any of this. This is more of a business owner type thing. The MSO does it. So we're talking about what's in your profit and loss statement, what's in your statement of cash flow statement, what's in your balance sheet. Where are you and where do you want to be? And then how do we get there? Are we achieving your yearly goals or not? Okay. And once again, it's broken down by quarter. And in that quarter, it's broken down by week. So like, where you want to go. And if you're not achieving that, what's going to get you there? And that's how most corporations look at things. They have their financial targets. They have their budgets, right? You need that budget, either third or fourth quarter. Some bigger companies do it, have it several years ahead. But having it several years ahead, I think, is too. There's not. You can't do it that way. There's too much change. So anyway,
Michael, let's take
yes.
There's a question from Emma.
Oh, great. I can't see I'm seeing my screen, so go for it.
Yeah.
If you want to interrupt, that's great. We can do that. Let's do it. Can you read it to me though? Because I really can't see the
Hello.
screen.
Hey, Emma. How are
Hi.
you?
Hi,
Hi.
Emma.
How are you? Thank you for
Good.
this.
Yes.
Um, Let me just turn off Alexa real quick.
Right. Alexa gets me too.
So, I have been running a DPC for about 18 months,
Mm-hmm.
and I kind of lead the Tampa DPC Women's Group. And
Awesome.
I think all this information is like fabulous if I had been running a private practice for 10 years and now I was meeting new financial challenges.
Mm-hmm.
But our pain points are like very simple, like much more simple than this. And I'm the only people I've found that can help are like consulting MDs, which I
Mm-hmm.
think may be going out of business. And their business model was, I think, 10,000 up front and then 35% of your revenue for the
Oh
first
my.
5 years,
Ooh.
which was ridiculous. And then,
Wow.
or you can pay, like, I would love to pay Alana Miller $40,000 to help me do everything properly. But I think there's a like a
Correct.
vacancy in the market for helping people like us that have literally no business
Mm.
knowledge. And it's just me and
Right.
my VA in the Philippines and one room.
Correct. And so that's a steep that's a really kind of steep charge for that's wild. That is not what I do. I want to help practices. If you're taking the revenue from the practice that's not making revenue, that's going to put you out of business. that's that's a tough way to do business, because you're stacking the deck against the provider who needs the help. So like that is certainly not our goal. My goal is to 5 to 10 times pay back a practice. You can't strangle the yourself. You can't have a practice that's needs the support, and you're bootstrapping them without the systems in place, especially the first year. And like you said, if you're starting your practice, it's a different model. It's a little bit of a different model. If you're struggling, it's still a sort of this model because you already have things built, right? It just needs to be amplified, fine-tuned. Some things need to be gone, like operations need to be gone. Some need to be installed. And a DPC practice, it's the same thing. Only honestly, someone like me could never. That's really steep. You can't do business that way. You're not helping someone by having that type of environment. You should be able to scale up as your practice grows. As your practice grows, there's a little bit more meaningfulness to your value. But yeah, I'm with you.
I
Um,
guess what I'm saying
it,
is like, is
yeah.
there anyone that we can reach out to for help? Because there are things that haven't occurred to us, like
Mm,
accountability. Should I pay Accountable HQ 2 grand to help me find all the BAAs that I need? Like, there's so much
there's a
that
lot.
I
It's a
need to
ton.
learn, and I can't do it all. So there needs to
Correct.
be someone who can walk these startup DPCs who are taking back medicine. Like the young
Right.
physicians
Thank
right
you.
now are all starting DPCs, and there needs to be
Thank
someone that
you.
can walk us through this.
Well, that's me. And I'm not out to uh, pull money away from a practice that it doesn't know how to generate it. Not doesn't know how to generate it, but has the potential to generate it and to live, how they want to live and not fold. Look, this is more of a movement. Like you said,
Mhm.
this is an environment where you can take back medicine, and I'm all for it. That's why I'm here. So what I suggest is maybe we jump on a little call and afterward, and we can talk about the nuances that you have and work through things, and be able to kind of get things where they would need to be. You know what I mean? Um, I I kind of jumping the gun, but I'm
Yeah,
offering
that would be
a free
awesome.
consult.
Maybe
Yeah,
a
free
new arm of your
consult.
consulting business.
Right. Like in literally it is that's the thing. It has to work. Oh my God, it has to
I know.
work. and you can't
Yeah.
bootstrap people, or no wonder they're going out of business. This, medical consulting companies, good, let them go, because they're
Yeah.
doing exactly what they shouldn't do. You can't do that. So
Yeah.
let's get on a call. Let's get on a call,
Okay.
free call. And I have my information at the end of this that you can just kind of click and do an appointment, and we can go through things from square
Okay.
one. You know what
Thank
I
you
mean?
so much.
Cool. Yeah.
And,
Yeah.
and you know, I don't get anything financially from this. I'm almost wondering if there's a bunch of Emmas out there, which I know that there are,
Mm,
getting together and doing like group, like rather than Michael, you usually do one-on-one
yes.
consulting. But in this case, there are a lot of people, they want to be solopreneurs. I call them, but they just want their own DPC. They don't even want to work with another doc. Like there's
Right.
pluses and minuses of that too. There really are. Like one of my good friends had told me very early on. I said, my husband too. She's like, "Do you cash all checks?" And I'm like, "Yeah, we're not gonna do business together."
Right.
I'm just,
And
I don't mean
and
to make a joke, but maybe there's a bunch of DPCs that can get together and you could do like group
100%.
with, you know.
I could, if there's enough interest, that is, I would have an event that's live. I actually could take certain practices that maybe aren't even, they're either startup, it's a little bit of a different process with startup, or they're struggling, or they just need a boost. I can take their practice and use it as an example. I would, do that for anybody on this call, and we can go through it as a group. If, you can kind of alter information that's private,
Yeah.
financial information. It doesn't have to be exact,
I
but
think the startups are most important in my opinion. I'll tell you why, because
yeah,
if the systems
I
aren't
agree.
there, they're not going to be
They're
going much.
not
So
right. That's it, but some people have done okay on their own. Like I said, in that early inflation time, when things were less expensive, and they were able to open up a wing of something, because, Medicare, I'm just going to go with Medicare. Medicare rates were higher, and then we had low overhead. So they started there, and then all of a sudden, this wave of inflation came in this, past decade, and those systems don't work anymore. So there's room for people who are startups. There's room for people who are stagnant, and then people who are declining need help now. You know what I mean? Um,
that,
the overall goal is, the more that autonomy of independent private practice stays that way and grows. And I'm so glad that Emma said, there's this wave of let's take medicine back. That's where I want to ride. That's what we need. That's medicine. It's not what's happening that we can't control. And I want to tell you that the independent physicians that, are cash pay, that is the biggest threat to the hospital systems. They know it. So that, I think, is the villain to this big conglomerate of hospital takeovers. These physicians who are capturing the patient physician relationship have a total advantage. And so I want to help them get to use it. Right? You have to have both sides. You got to have the the um the, the business side, and you have to have the clinical side. And I think most physicians have the clinical side down pat, if they're allowed time with their patient. You give that you give that time with the patient, with the physician, and you win. You beat any medical system, because I'm going to call a hospital and not get in for 10 weeks. And then I'm going to see the physician for 4 seconds, because the administration told them they could only see them for 5 minutes. And then they give me a script to get something done. And then I'm wondering, well, what's wrong with me? You know, like reverse order of things. And that's why the advantage to the independent physician is out there. So I'm excited for it, actually, because it means everything. When we talk about the future, we talk about the future of rising costs and what's going to save costs. And it's legitimately things like this. There's no administration telling, wasting, I'm not going to say wasting, but exorbitant money and monopolies taking over what should be really between the physician and the patient. And it's much less cost, much less cost. You know what I mean? Okay. Other questions we can take. Let me just get through this a little bit and then we can take more, which is fine. If there are some, that's okay. Cool. Because I can't see, I can only see my screen, which is interesting. I'm maybe not technologically there on this. Okay, so let's keep going a little bit. There's just a little bit more, couple more slides. We were talking about finance, right? And provider productivity is super important. In this debt part of the dashboard, which most people will have this type of dashboard in a the MSO kind of our thing. We're looking at what the revenue per hour is bringing in, their labor costs, the actual, how many patients they're seeing, of course, and the goal for the visits. And you can benchmark it. And where is this coming from? Like, why do we care? Well, we care because we had set financial goals, didn't we? We set them at the beginning of the year, and there you have to change them accordingly. But if we know what our labor is going to cost us, and we know that we bring in, that our throughput, how the patients come through our system, produce this amount of savings in the system, we can then accurately or semi-accurately, it's not perfect, but it's way more accurate than anything else. We can then have decent projections of what's going to happen from day 1 of 2026 to day 31, the last month of 2026. Predictability is keeps people from, it makes people sleep at night, makes the physicians sleep at night. We need consistency and predictability, period, right? Okay, let's keep going a little bit and then I'll open it up a little bit. This was kind of like our financial dashboard for the week. We kind of went through this gross charges, net collections, payroll, and then it goes to monthly financial dashboard. So weekly, if weekly's on track, I hope in 4 weeks we get to the monthly, and it looks like we're doing pretty good there. Then I'm going to go to there should be a quarterly, but I don't have that in here. Yearly, okay, we met our goals. Great. If we didn't meet our goals or operating expenses, this chart is pretty easy. It doesn't include financial. For instance, it's operational, but it's not really, like, we don't have, if someone's taking out a loan, then we have to add amortization to this whole thing. We have to add interest payments into this whole thing. And then there's a tax side of this. And the tax side of it is, can we write off something? Did we buy a new x-ray machine? Okay, should we have bought an x-ray machine? Or should we have rented the x-ray machine? Okay, there's all kinds of stuff here. How many people do we need to put in that x-ray machine to pay it off? All right, and then can we sell the x-ray machine when it starts to get old? Or was it better to lease the x-ray machine? And then at the end of the machine's life or technological advancements makes it obsolete, then we give it back, right? All of these are important in the MSO. They're important to really, you don't want to make those mistakes. You make a big mistake, like $100,000, MRI machine or X-ray machine, that's a big piece that can sink you if you don't have the infrastructure to support it, pay it back, and profit off it. The goal is to not just pay it off, although it can be if the rest of your systems is if that X-ray machine is diagnosing things 5 times quicker, and on the back end, there are support services that are operating because you did that X-ray, but it's not making you a dime, but you're paying it back. Fantastic. The other service lines are supporting or subsidizing the X-ray machine. Fantastic. Okay, so it's not so bad if you can't pay it. If you can't profit off of it, doesn't matter as long as it's making other parts of the business survive. Okay, so all of these can be financially looked at and beforehand, before buying the X-ray machine. And that's kind of what an MSO will do too. It'll tell you what equipment is going to work for your practice, right? Okay. If you have 2 clinics, I put in here, there's Sycamore and then there's Turrock. What a terrible name that I made up. And then you can compare the 2 locations. Okay. And like I learned from our locations, you have to have a system of control that is applicable to both systems, to both locations. Okay, so the systems have to be in both locations. Your standard operating procedures, how you do things has to be pretty aligned. It's not going to be exact. You're going to have a culture that may be a little bit different than the other site. You may have a little bit of supply chain throughput might be a little bit different. How things are laid out might be a little different, but you want to make them as close as you can. And then these two locations have to communicate well. So that brings in the organizational leadership portion of the process. Your managers, your if there's just clinicians that are physicians that are owners, if there's 5 owners, well, one of them is going to have to take the operational aspect of things, might be seeing patients a little less, but organizing the unity of the culture of the 2 locations. So that's a little bit more, but very important. Okay, there's 2 more pillars here, and then I will almost be done. Okay, revenue cycle management, super important. Okay, for the docs that are taking cash payments, it's pretty simplified, and it's cool. I want it to be not crazy, but for those taking insurance, I always say, what is the revenue cycle? The revenue cycle is the minute, the second that the physician hits the billing button to bill a certain code. That is the beginning of the cycle. The end of the cycle is when the check is cleared from the insurance company. Okay, so when it hits the bank, the minute that it hits the bank, the process all the way through that is this cycle. Okay, and there's a ton of stuff that can convolute the way you get paid, from timeliness to billing. Did your provider, as soon as they were done, did they hit the billing button, or was there lag? Was there lag in when they do their billing, their notes and billing? What is your EMR looking like? How fast can that claim get billed out by the biller to the clearinghouse, and from the clearinghouse to the payer? And then is that coding scrubbed so that it goes streamlined through it? Or did it get kicked back because a gazillion reasons? It might be the code's wrong. We don't authorize this. Like, all that stuff has to be caught before it even goes out to be streamlined. And then on the back end, when is that dollar hitting the bank account? How is that set up? It should be direct deposit right into a bank account. Good, great, fantastic. But here we go. I have different payer mixes. I have workers' comp, which there might be a 90-day window before they end up paying a claim or more, and then I have Medicare, where there's a 2-week window, direct deposit. It's pretty streamlined. Okay. But if things are getting kicked back because the codes are wrong, or they deny codes, which they love to do, then there goes your, that's margin. You know what I mean? It's margin. So anything that's in lull, 30-day, 60, 90, and 120-day window, your payer mix, you don't want anything beyond the 60-day hanging out there. You will never collect something, or rarely, in the 90 to 120-day receivables window. So you want to keep that tight. 30, there's a lot that's not collected, and you want to catch it in that 60-day window. And if not, where is it caught? Why are we having these problems? Why aren't you getting paid quicker? Okay. In cash pay systems, you're not, you're still on the hook. What does that look like? Does it look like pay up front? Does it look like you're billing them? Don't want to really, if you can get away with that and not do that, that's great. But it's the same cash flow cycle, but it's a little bit less, and it's actually streamlined, and I love it. But there are big nuances with that as well. There's lots of practices that are not capitalizing on the right cash flow management. Okay, number 7, and then, I'm sorry to fill your brain with a bunch of stuff, but insurance payer mix. This is more for, once again, the insurance based practice. Okay, this is super important. So if I have my majority of reimbursements, right? Reimbursed payers is commercial. Okay, I have what, 34% commercial. I've got 24% Medicare. If I'm getting underpayments, meaning the contract is saying that I'm getting paid this, and then they're really paying me this because they have 15 different plans or 25 different plans. We have kind of ways to find that out. Okay, I have some colleagues who look into that to see, are they undercutting you on your payment? Very important. If you save $1, you save on each CPT code, it can turn into thousands and hundreds of thousands of dollars that you don't know that you're getting. On the other side of it, there is one of my partners has an ability to see if you are getting reimbursed per your contract the same as your competitor down the road is getting paid their contract. So he has access to every single organization, including the ones that you have if you're billing insurance, to then see if your competitor is being paid per CPT code the same as you are. And guess what? Sometimes it's worth looking into, because then you can renegotiate those contracts. You can send letters out, and then you can meet eventually with the provider of the one of the providers of the network. Usually it's like a VP or like a manager, and renegotiate your contract. There's more power in this than there used to be. So if I have 24% or 34% commercial in my, and they're paying me, let's just say for a low E&M code or something, they're paying me, let's just say like $70 per my evaluation, my initial examination. And first of all, are they paying me what I should? Is it $70 or $65? Well, that makes a big difference. It's $5 difference is a huge deal. But let's just say that most of my volume is in the commercial space. Well, okay, and they're paying me less. Let's say my contract is $50. I need a tremendous amount of volume to make that up, as opposed to a contract where maybe I'm making $200 for the CPT code. You need less patients to come in. So literally, the payers that are low performing, the ones that, and remember, there's a volume component to this. Low payers need to go. All right. The contracts need to be renegotiated, or they need to be out of network. It's dragging your practice down. You're using, remember, we talked about the supply chain, the finance. You're using all of your resources to fund a low payer with a higher amount of volume that gets you less revenue. Okay. So you can see how that works. It's volume based in this place. All right. And it may be worth lopping them off. There's 2 payers that we all deal with in the commercial space, and you probably already know what they are, those of you who are insurance based, that are not worth having, unless your area where you live in, the majority of those patients have those insurances. So you need to know the percentage of kind of payer contracts out there in your region, because if you just cut it off because it's a low performer, you might be cutting off your bloodline, because your region supports that insurance more than any other insurance. So you're going to have to play a volume game where you've got to see a volume of patients. If you got rid of those, you wouldn't be competitive with other physicians in the community. So you can't do that. A lot of people just cut off the low payer. Well, you can't if your volume, and there's ways to find out. It's really not hard. It's just a couple calculations to find out how much you need, of this payer. Okay. And that's just part of your portfolio of all of these insurances that you have. It's important to know the payer mix, the volume of the payer, how much is coming in, like numbers wise, and then also the reimbursement rates. Usually it's a combination of all of this that will get you your revenue per visit. It's an average, your cost per visit, and lets you know that, okay, this payer is 1%, and I get paid $50 just for like an initial examination, and the volume is 10 patients a year. It's time to go. Okay. So just letting you know that that's a real thing that has to be looked at. And then we talked about contracts and contract negotiation. That's part of, what an MSO looks at to see if you're getting the rate if you are insurance based. I just talked about this. I kind of jumped the gun. Here's practice A. Here's practice B. And practice A is getting 118 overall for their name a code or per visit. Okay, all your codes together also equal one visit, and the mixture of those codes that you would normally use, let's just call it 118. And then practice B has 131, and they're the same practice. They're the same type of practice. Well, why is that the case? Why are they getting more? And then you can kind of go back to your contracts and start talking to those payers. Okay, very important. You could lose thousands of dollars by not having the same payer rate. Okay, so offered in anyone who wants to have a free conversation, you can book a consultation. You might be able to, I don't think you can click on this. You might be able to click on it, but you can copy this and just paste it into your browser. That's the scheduling page, okay? What we do is we'll take a look to see if we're even viable for your practice. There's lots of things I covered today, but some people need some bits and pieces, some people don't. And there's what I usually do if people want to work with us, I just begin a 90-day paid alignment, which sets you up for the systems that you need to have. And it's very specific to your practice. So some practices don't need, practices are different, just like people, just like patients. Everybody's different. So, and it's not to say a 35% margin, oh my goodness, and $10,000. That's just not happening. That's ridiculous. It is per practice, there's a certain amount at what level you're at. The goal is to 5 to 10 times your practice in being able to be profitable, not to steal from the practice. That's like not what is good practice. A bonus is if anybody wants to just simply have their CPT codes analyzed for, am I getting the same thing as my neighbor down the street? I would offer to do that as well, just to take a look at it. Because really it's harder to then get the relationships with the payers to then say, hey, listen, you're kind of screwing us over. So I would do that for anybody, just as a bonus for anybody being on the call or seeing it on YouTube. And so that's super cool. I think that is my last slide. Yep. Once again, free consultation is there. A 90-day alignment can happen, and then an operating roadmap. Find out where you're leaking in your margins, prioritize the highest, impact operating systems, and then literally being able to keep your practice moving forward ahead of the curve. We know inflation's happening. We know Medicare is going to cut. We know all these things are going to happen, but we don't have to be part of them. We can strategically be on the front line, ready to pivot when this stuff happens. And literally practices are surviving knowing these things with the MSO. Okay. So what I'm going to do is I'm going to maybe try and go back to, here we go. Go back to this. Oh, that's terrible. I'm going to get out of this and stop sharing. And then maybe I can come back on. Oh, there I am. Could you see me the whole time? Because I could be making faces and not even, I was looking at my screen, so I didn't really know what you could see. Hopefully just the screen, but
Everyone is just looking at the slides. It was perfect, Michael.
Oh, cool.
Very extensive. I hope
Good.
that I loved how you break it down into buckets and
Mhm.
steps and whatnot. And it really is important. It's like multi-factor.
So important.
So
You don't know what you don't know. And, from studying business, it makes it clear, but the business people, here's the crazy thing. The business people don't know the medical side. The medical people don't really care for the business side, but that line, the patient care line, the sanctity line has been violated, like back and forth, more from the financial side and the business side than the medical side. This medical side just wants to treat their patients the best way and be able to continue to do that. That's like what we're after. But the financial end will just, I mean, it just destroys it. It has no care in the world for any type of relationship from a patient. They're just seeing the number side of it. I've looked at the number side of it and I'm like, well, why is this happening? Then I can jump into the operations side and make sure that the sanctity of the patient physician relationship is primary. I don't care how the finances work as long as that's once you establish that and the systems around to support it, you're kind of like bulletproofing. You know what I mean? You're able to see both sides of it. And I'm very lucky to be able to do that right now. Very lucky. hmm Yeah. I'll take any questions if anybody has them.
Robin, any questions?
Yeah.
Tommy? Percy, you were on the whole time. So, well, that's
Oh.
really, any questions at all from anybody?
I just want to say thank you for breaking everything down.
Mhm.
Physicians, a lot of times we don't get this at all. And you just
Mhm.
broke down every single issue I'm having in my practice.
Okay.
And I appreciate everything you talked about tonight. It's good to know that the issues that we are having, they are problems that other people are having.
100%.
I
Yeah.
appreciate
Well, I appreciate coming on and giving me, and people need help, right? And I'm ready to offer help for folks who are struggling or don't know where to turn. Remember, that was me. And I needed to know more so I could survive. So it really comes back to just being able to put the pieces into place to make sure that the autonomy is preserved in the relationship. And you can't do it just by practicing. I used to think you could just see more patients. That sounds great. Just see more patients. Come on. You can't. That's it. Those are the old ways. This is 2026, and you need more than that. You need this infrastructure to be doing it yourself. And that's what I'm here to help with. So that's good. So thank you. Yeah.
Any other questions? It's a lot to absorb.
It's a lot. I'm glad you're able to play it back because I mean, you guys probably were working and it's, later and wherever you are. And it's intense. Think of the time you don't have to do any of that because it's real. You spend all of your time trying to, make the patients healthy, and it's a tribe that has to build a practice and keep it together. It's more than just more solopreneur. You get all the compression on that's crazy. So, yeah, I welcome anybody who wants to talk more, of course. And Sharon as well. I would love to set something up live. Would be cool too. I'm all for that. If we want to keep talking, if there's interested parties in, I'll break down their practice and then we can build it up from scratch. If people are wanting to get into their own practice and don't know what the startup's like, we can build it for them and show them what's most important. And then we can take a look at, here's your cost sheet. And here's what you need to start bringing in. If you're going to finance things, which a lot of folks do, which is a very good way, don't be scared. What's that going to look like, from the bank? So it's very, very important. And once again, you guys can reach out to me individually, of course, always. And then also, Sharon if there's interested parties, I'd love to host something live. I don't know if people want to come to Pittsburgh, but I would go to, and it's a great town. It's phenomenal. But I would go to another city that's more, people can get to, that kind of thing. So it's all out there for you.
Thanks so much again. I really appreciate it.
Yeah.
I might show this goes out on YouTube, and then I have to put that event goes out every Sunday with a pretty good open rate. So I'll make sure
Cool.
that it's the replays in there as well.
Awesome. And anybody on the replay can easily click on the link and have schedule a call, and we'll just talk. Like, there's a no pressure way to talk, right? It's called communication. So there's lots of concerns in different parts of people's practices. So I'm willing to help, and it's actually it's fun. I know that's weird, but it's fun. It's fun to help build something great. Cool.
I hope everyone has a wonderful night. Thank you again.
You too. Thank you.
Me too. Thank you guys for being on. Appreciate it.
Thank
And have a good
you.
night.
Bye.
Bye bye.